Hi everybody, and thank you for joining me in this new short video presentation regarding ECG exercise number 21. I hope you will enjoy this video and join me here in my future video presentations. If you are new to my channel, please do not forget to subscribe. Now let's go together directly to the presentation. So our patient is a 44-year-old man with schizophrenia who was admitted to another center due to wide complex tachycardia and recurrent syncope. Echocardiography and coronary angiography were normal, and cardiac MRI was not possible, and an ICD was implanted at the referring center with a diagnosis of recurrent ventricular tachycardia and syncope. 2 months later, after 32 ICD shocks, the patient was referred to our center for catheter ablation. Here we see together the ventricular tachycardia, or the wide QRS complex tachycardia, better to say. The wide QRS complex tachycardia, we see the right bundle branch block pattern. And now the question is, what is the underlying cause for this wide QRS complex tachycardia? What is the diagnosis? So the first clue comes when we compare the ECG with the sinus rhythm. On the left side, we see tachycardia. On the right side is the sinus rhythm. And when we compare both ECGs together, we see that the axis and the morphology is quite the same. But during tachycardia, we have a wider QRS complex, but these wide QRS complex looks exactly or very similar to what we have in sinus rhythm. So this is the first clue that should alert us that this wide QRS complex tachycardia might be not a VT. Now we go further and look at this baseline ECG, and this is very interesting. We're starting with the sinus rhythm, P, QRS, and T, and then the P wave, and then after this P wave, we have 2 QRS. And here is another clue to the possible diagnosis, actually double ventricular response, which is a sign for dual AV node physiology. And we see it again here in the ECG, again a double ventricular response. Now we go further to another ECG, and this is very interesting. On the right side, we have a still double ventricular response, and on the right side, we see a non-sustained tachycardia. Here we have the sinus rhythm, right bundle, sinus rhythm, then double ventricular response and the non-sustained tachycardia, which exactly looks like the second QRS in double ventricular response. And actually, this is a non-sustained AV node reentrant tachycardia. This is another ECG of the patient in the baseline EPS study. In addition to double ventricular response, we see some outflow tract PVCs. And we know that these outflow tract PVCs and AV and RT happen not uncommonly together. And this is another clue to the diagnosis. So, and here we have the final clue to the diagnosis. And this is the ECG and intracardiac electrogram during EPS study. And as you can see here, the diagnosis is typical AV and RT. And actually, this patient received an ICD for the very fast AV and RT, which usually resulted in syncope in this patient. So the slow pathway was successfully modulated. The tachycardia was not inducible at the end of the procedure, and after a slow pathway modulation, as you can see in this ECG, we didn't see double ventricular response anymore. So in conclusion, that was a young man with wide QRS complex tachycardia. Although the most common cause of wide QRS complex tachycardia is a ventricular tachycardia, in such cases, when we have some clues in the ECG suggests that the underlying cause of wide QRS complex tachycardia is not a VT and more probably is a supraventricular tachycardia with aberrant conduction, then we have to do the EPS study. In addition to ECG criteria, this patient has normal coronary angiography and normal echocardiography, normal size right ventricle and left ventricle normal size, and also normal LV and RV function. So that was another possible criteria for thinking on supraventricular tachycardia. So at the end, I hope you enjoyed this short video presentation, and I would like to invite you joining me here in my future video presentations. Thank you.